Right now, before you move a muscle, reach behind your neck toward the top of your shoulders and run your fingers across that junction. If you detect a solid mound or thickened tissue where your neck transitions into your upper back, you are not simply dealing with poor alignment. You are dealing with a structural accumulation that is actively compressing the vascular pathways, delivering oxygen-rich blood to your brain. And here's the critical insight that nearly everyone overlooks. This formation can begin emerging in your third decade of life. Not in your 60s, not following reproductive decline, but in your 20s. If your routine mirrors that of most individuals living in the modern world, if you value health information presented with this level of clarity and directness, consider subscribing and engaging with this content. Engagement signals help this material reach a broader audience, and the target is reaching 200,000 individuals who benefit from this work. You are contributing to that outcome. Additional resources and practical guides are available through my channel on messaging platforms. Access those tools using the code displayed on your screen at this moment. Let us begin with a concept you probably encountered in an anatomy course and promptly dismissed as irrelevant. Your vertebral column is not a vertical rod. It is a carefully orchestrated series of 4 distinct curves. First, the cervical lordosis, which is an anterior concave curve at the neck level. Then the thoracic kyphosis, a posterior convex curve running through your upper and mid-back. Then the lumbar lordosis, anterior concave once again at the lower back. Finally, the sacral curve at the pelvic base. These 4 arcs function in concert as an integrated shock absorption system. They dissipate forces when you ambulate, when you accelerate, when you lift objects with mass. When these curves become distorted, when one is amplified or diminished beyond normal parameters, the entire mechanical system loses its capacity to distribute load evenly. Stress becomes concentrated at vulnerable junctions, and structural breakdown begins. The cervical region is one such vulnerable junction. 7 vertebrae stacked sequentially, supporting a cranium that weighs approximately 11 pounds. 11 pounds seems reasonable, until you comprehend what occurs when that cranium shifts anteriorly. Biomechanical research demonstrates that when your head tilts forward merely 15 degrees, the sort of inclination you adopt when glancing at a mobile device, the effective force acting on your cervical vertebrae escalates to roughly 26 pounds. At 30 degrees, it reaches approximately 40 pounds. At 60 degrees, the angle frequently maintained when reading in a reclined position with a screen held overhead, the force approaches 60 pounds. That is nearly 6 times the baseline load sustained continuously for multiple hours daily. Your cervical musculature was never engineered to handle that demand. No human musculature was. So what precisely is this protrusion? Clinically, it is a concentrated deposit of adipose and fibrous connective tissue that develops over the 7th cervical vertebra, the terminal vertebra of the cervical column. You can palpate it yourself immediately. Flex your head forward and locate the most prominent bony prominence at the base of your neck. That is C7. In a spine with optimal alignment and healthy posture, nothing sits over that landmark except integument. The protrusion, often referred to as a Dowager'S Hump or widow's hump, develops when sustained muscle spasm, compromised vascular perfusion, and stagnant lymphatic clearance converge in that anatomical region, and adipose tissue begins to accumulate in response. The term widow's hump originates from a genuine epidemiological observation. This condition was historically most prevalent in women transitioning through menopause, and there exists a clear endocrine basis for this phenomenon. During menopause, circulating estrogen levels decline precipitously. Estrogen, the dominant female sex steroid, does not merely coordinate reproductive function. It also determines regional fat storage patterns. When estrogen is maintained at physiological levels, adipose tissue preferentially deposits around the hips and thighs. When estrogen diminishes, fat distribution undergoes a metabolic shift. It migrates away from those regions and begins accumulating in the abdominal cavity, the upper extremities, and the upper dorsal region, including the cervicothoracic junction. This is not a behavioral deficiency. It is an endocrine transformation that alters lipid metabolism at the cellular level. But here is what has fundamentally changed in the past 2 decades. You no longer need to be experiencing menopause to develop this condition. You simply need prolonged seated work, a smartphone, and a few years. Clinicians are now documenting this formation in individuals in their 30s, their mid-20s, and occasionally younger, occurring with equal frequency in males and females. The primary driver is no longer hormonal fluctuation. It is 8 to 10 hours daily in anterior head posture, followed by additional hours on handheld devices. The musculature maintaining that position eventually loses the capacity to release. It becomes locked. That locked state has a clinical designation: chronic muscle spasm. A muscle in spasm is not simply shortened, it is failing to undergo relaxation, even during periods when it is not actively recruited. It remains metabolically active, consuming oxygen and glucose, while simultaneously constricting the vascular channels and lymphatic vessels that traverse it. The upper trapezius, the large superficial muscle extending from the occipital ridge down to the mid-thoracic spine and laterally to the clavicle, overlays this exact zone. When it enters chronic spasm, local perfusion becomes restricted and lymphatic drainage ceases to function effectively. Lymph is the interstitial fluid responsible for removing cellular waste products from tissues. When lymph cannot drain, the region becomes congested, inflamed, edematous, and predisposed to lipid deposition. That is the mechanism by which a firm, occasionally tender ridge forms at the cervicothoracic junction. In the initial phases, you might perceive it as a vague sensation of heaviness across the neck and shoulders, grinding or clicking sounds when you rotate your head, and these are not benign findings. These sounds indicate that the facet joints in your cervical spine have lost their normal biomechanical glide. Headaches begin to manifest, typically at the occipital region or the temporal areas. Tinnitus develops, difficulty initiating sleep. Sometimes, and this catches individuals off guard, blood pressure begins to trend upward and does not fully normalize with pharmacological intervention, because one contributing factor is positioned directly at the base of the skull. There is a well-documented clinical case pattern in primary care settings that illustrates this connection clearly. A patient, a 52-year-old administrative professional from the Midwest, presented repeatedly for tension-type headaches and mild essential hypertension. She had been receiving antihypertensive medications for 2 years with suboptimal control. A comprehensive physical examination revealed a prominent hump at C7, significant trapezius hypertonicity, and markedly restricted cervical range of motion. Once her treatment team addressed the cervical dysfunction through structured physical therapy and specific exercise prescription, her headache frequency decreased markedly, and her blood pressure readings achieved more stable control. The cervical hump had been an overlooked contributor to her cardiovascular dysregulation throughout that period. Here is why that connection is physiologically sound. Running alongside your cervical vertebrae are the vertebral arteries. These vessels ascend through foramina in the transverse processes and supply the posterior circulation of the brain, including the cerebellum, which coordinates motor control and equilibrium, the brainstem, which regulates cardiac rhythm and respiration, and the occipital cortex, which processes visual information. When the tissue surrounding C7 is hypertrophied and the surrounding musculature is in sustained spasm, these arteries can undergo compression or distortion. Reduced perfusion to those neural territories means diminished delivery of oxygen and glucose. This is not a trivial consequence. Medical documentation from vascular neurology clinics records a correlation, not an absolute causation in every instance, but a recognized pattern between substantial cervical hump formation with sustained circulatory compromise and progressive cognitive decline. Memory difficulties, impaired concentration, diminished executive function, and multitasking capacity. Separately, a frequent complaint in these presentations is paresthesia in the digits, especially during sleep, caused by nerve root irritation in the cervical spine. A patient awakens with hands that have lost sensation, undergoes a series of cardiovascular evaluations, and the etiology is ultimately traced to the neck. In advanced scenarios, when the intervertebral discs, the fibrocartilaginous cushions separating each vertebra, have been subjected to chronic overload for years, they can herniate. That means the nucleus pulposus extrudes beyond its normal anatomical boundary and applies direct pressure on neural elements. That situation frequently necessitates surgical intervention. This is why dismissing it in the early stages is a strategic error. The encouraging news is that 3 specific exercises, each targeting a distinct component of the dysfunction, can interrupt this cascade, reduce spasm, restore perfusion, and retrain the musculature responsible for maintaining postural alignment. These are validated movements from rehabilitation medicine, not unproven trends. That said, if you already carry a confirmed diagnosis involving your cervical spine, such as disc herniation, vertebral instability, or significant degenerative joint disease, it is prudent to review these interventions with a neurologist or physical therapist before initiating them. The first exercise is termed the chin retraction, and it is among the most extensively validated techniques in cervical rehabilitation. Physical therapists employ it routinely. Its target is the suboccipital muscle group, a collection of small, deep muscles attaching directly to the atlas and axis, the first 2 cervical vertebrae, positioned just beneath the occipital bone. When your head resides in an anterior position day after day, these muscles remain chronically shortened and contracted. Their spasm is a primary generator of occipital headaches and that oppressive, pressurized sensation at the posterior skull. Here is the execution. Stand upright with neutral alignment. Allow your shoulders to descend naturally. Visualize a thread attached to the crown of your skull, gently elevating you. Place one fingertip lightly against your chin. Not exerting force, merely providing a reference point. Now, draw your chin straight backward away from your finger as if creating a double chin appearance. The critical detail, your head does not extend backward and does not flex downward. It translates purely in the horizontal plane. Your shoulders remain motionless throughout. Hold for 3 seconds. Return gradually. Repeat 10 times. You may perceive a mild stretch at the skull base. That is expected and therapeutic. If you experience pain or vertigo, discontinue immediately. What this accomplishes mechanically, by retracting the chin, you decompress and elongate the suboccipital muscles and shift the cervical spine posteriorly toward its neutral curvature. Performed consistently, this retrains the default position your head adopts. Neuromuscular memory is both the problem and the solution. The second exercise addresses something most individuals neglect when focusing on a neck problem, the thoracic spine, meaning the mid-back region between the scapulae. Your neck and your mid-back are not independent systems. They are one continuous kinetic chain. If your upper thoracic spine is rounded anteriorly, which for the majority of individuals who work seated it is, your cervical spine has no biomechanical option except to thrust forward as compensation. Addressing the neck in isolation while ignoring that thoracic flexion is analogous to attempting to straighten a tilted picture by adjusting only one corner. You must open the anterior chest. Stand erect, shoulders retracted and depressed. Interlace your fingers behind your occiput with your elbows oriented anteriorly. Now, gradually draw your elbows posteriorly as far as comfortably achievable, while simultaneously pressing your shoulders downward and backward. Sense the stretch across your anterior chest and along the sternum. That is your pectoralis muscles lengthening. Hold for several seconds. Then slowly bring your elbows forward, maintaining depressed shoulders, and sense the stretch across your upper posterior back between the scapula. Repeat 10 times. This repositions your scapula to their anatomically appropriate location, elongates the adaptively shortened pectoral muscles that are drawing your shoulders forward, and releases tension in the precise region where the hump develops. One essential detail: your shoulders must remain depressed throughout the entire movement. A prevalent error is allowing shoulder elevation as the elbows retract. That diverts the mechanical load away from the target muscles and substantially diminishes the exercise efficacy. The third exercise transitions focus from stretching to strengthening. Your postural extensor muscles, those responsible for maintaining your spine in an upright posture, undergo deconditioning when you spend years in a flexed position. Not because of any intrinsic pathology, but simply because they have not been fulfilling their functional role. The passive structures, ligaments and tendons, have assumed that responsibility, and that accelerates postural deterioration. Hands interlaced behind your head once more. This time, instead of spreading your elbows laterally, press your hands posteriorly away from your skull while maintaining your elbow position. Sense your upper back musculature activate and your scapulae adduct toward the midline. Hold for 1 to 2 seconds. Release. Repeat 10 times. The movement is subtle, but it directly recruits the deep spinal extensors, the rhomboids, and the middle fibers of the trapezius. Precisely the muscles that become inhibited when posture degrades and require reactivation. Execute all 3 exercises in sequence. It requires 5 to 7 minutes. Most individuals experience a perceptible reduction in cervical tension and improved ease of head rotation immediately following the session. That is not a psychological effect. It is the direct consequence of enhanced circulation in the cervical region. Now, a discussion about manual therapy. Targeted work on the hump zone is effective for dispersing the congested adipose and connective tissue. However, there is a significant caution here. Aggressively self-treating the area overlying C7 without adequate anatomical knowledge is not without risk. Major neurovascular structures traverse that zone. Applying excessive pressure in an incorrect vector can intensify spasm, irritate nerve roots, or compromise vascular flow. There are documented instances in clinical practice where patients who performed aggressive self-massage in this region subsequently presented with worsening digital paresthesia and intensified headaches, precisely the opposite of the intended outcome. If you desire effective manual treatment in that zone, it should be performed by a credentialed professional who understands cervical anatomy and has specialized training in working with the neck. If regular professional manual therapy is not accessible, vacuum-based massage devices represent a reasonable alternative. They promote lymphatic flow and local microcirculation without applying deep mechanical pressure to underlying structures. Initiate at the lowest intensity setting, avoid excessive pressure, and anticipate visible erythema afterward. That is, physiological hyperemia, indicating increased surface blood flow, and it resolves within an hour. Pain, numbness, or significant discomfort are indications to cease. The third pillar is nutrition, and it is the component people most consistently undervalue. The hump is not solely a muscular dysfunction. It has a substantial adipose component. And if dietary patterns remain unchanged, the lipid layer continues accumulating even as muscular function improves. Exercise and manual therapy alone will plateau without nutritional modification. 4 dietary interventions warrant discussion with a physician or registered dietitian, particularly if you have underlying metabolic conditions such as diabetes mellitus, thyroid dysfunction, or dyslipidemia. First, dietary fiber. Fiber, present in vegetables, fruits, legumes, and nuts, resists digestion in the small intestine. It undergoes fermentation in the colon, nourishing beneficial microbiota, attenuating systemic inflammation, decelerating absorption of glucose and lipids, and prolonging satiety. All of these effects contribute to improved weight regulation and decreased visceral and subcutaneous adipose deposition, including at the neck. Second, complex carbohydrates. Steel-cut oats, buckwheat groats, brown rice, these slow-digesting carbohydrates circumvent that mechanism entirely. Third, protein at each meal. Protein provides the essential amino acids your musculature requires to repair and hypertrophy. Without sufficient intake, the muscles you are attempting to strengthen through exercise will not recover and rebuild effectively. Protein also possesses a high thermic effect, meaning your metabolism expends considerably more energy digesting it compared to digesting lipids or carbohydrates. Sources include animal proteins, fish, eggs, cultured dairy products, and legumes. Fourth, reducing simple carbohydrates and saturated fats. White flour products, baked goods, sugar-sweetened beverages, and highly processed convenience foods produce rapid glycemic excursions, rapid return of hunger signals, and efficient adipose accumulation. This does not imply permanent elimination of all palatable foods. It means that if these foods constitute a substantial proportion of your daily caloric intake, progressively replacing them with the foods mentioned above is likely to yield measurable effects, especially regarding the adipose component of the hump. People occasionally report, "I consume very little, yet the hump persists." That is a recognizable clinical pattern. Adipose tissue in the cervicothoracic region, particularly following hormonal transitions, responds more gradually than abdominal adipose. It requires sustained consistency across all 3 modalities: movement, manual therapy, and nutrition, working synergistically over an extended time frame. After age 40, skeletal muscle mass begins declining at a measurably accelerated rate. Hormonal shifts accelerate the fat redistribution process, and the hump tends to form and progress more aggressively within that demographic. How old are you currently? Share your age in the comments section. Understanding the age distribution of this audience enables future content to be more precisely targeted and directly applicable to your specific circumstances. Here's what you should extract from this discussion. The cervical hump is not an aesthetic anomaly. It is an indicator of chronic postural dysfunction, sustained muscle hypertonicity, and compromised perfusion through the vessels supplying your brain. In early stages, it manifests as cervical tension, headaches, tinnitus, and sleep disturbances. If unaddressed, it can advance to nerve compression, digital paresthesia, progressive cognitive symptoms, and in severe cases, disc herniation requiring surgical management. The 3 exercises presented here constitute a sound initial approach grounded in rehabilitative science. However, if the hump is already prominently established, consulting a neurologist or orthopedic specialist initially makes practical sense to evaluate the current state of your cervical spine, exclude structural pathology, and obtain recommendations tailored to your individual anatomy. Exercise serves as a complement to medical evaluation, not a substitute for it. Apply what you have learned here to formulate more informed questions at your next clinical appointment. This information is designed to enhance that consultation, not replace it. If this provided genuine value and practical utility, consider subscribing and engaging with this content. That is what propels this channel toward 200,000 subscribers. Access additional resources and practical guides through the messaging platform linked on screen at this moment to receive ongoing health posts and actionable reference materials.